Joining us, as I promised you the last couple of days, is Dr. Fleisher, a cardiologist at ACMC. How you been doing?
Good. How are you, Pat?
I'm doing well. Somebody told me you went across the pond here recently.
You know, I just got back from a trip to Ireland.
Ireland? I'd love to go to Ireland.
A little bit of business and pleasure.
Yeah?
And we had a very good time.
Did you kiss the Blarney Stone?
No, we actually were planning to go there one day. And,
really?
And just ran out of time to
go
there. We were staying in Dublin.
Beautiful countryside, isn't it?
It is absolutely gorgeous. It's a beautiful country.
My mother's Irish, and I've always kind of wanted to go there to see it. And how long is the trip? I mean, is that quite a flight?
It's about a 7.5-hour flight out of whatever portal you leave from the East Coast on. We connected out of Atlanta, and it was about 7.5 hours into Dublin from there.
Not too bad.
No, it's really not bad at all if you can sleep on an airplane.
Yeah, right. I understand that. We always have Doc in at least once a month if we can. And you said you have something new at the hospital. Yeah,
we're, in the past, on one of our programs, we talked about what we call syncope, which is fainting spells or loss of consciousness. And it's a fairly common problem, and it occupies a lot of hospital time, physician time, because of just the sheer number of people that have this. And while we think about loss of consciousness, about low blood pressure, slow heart rates, it also kind of dovetails into another common complaint that we see with patients, which is palpitations, or feeling like their heart is either out of rhythm or going too fast. And all of this is wrapped up together in a kind of a common bond. And so as we see a lot of these patients, we obviously send them for a lot of tests to try to find out the cause for this. And one of the tests that was fairly common and was fairly easy to do is called a tilt table test. And a tilt table test is fairly simple. We have a patient lie down flat on their backs on a table, and we let them relax there for 10 minutes, keep the lights down low in the room and keep it quiet, and we monitor their heart rate and their blood pressure for 10 minutes. And then after 10 minutes, the table tilts up to a standing position. Now, I've been quoted a number of different times, and people come in and tell me for one reason or another, they told me they thought I was going to turn them upside down. But it's nothing sordid like that. It's simply a table, has an electric motor, and it's capable of going from a flat position to a standing position. And it has a footboard on it so that as it tilts up, your weight is, you're standing on your feet as if you were standing up. It has some safety belts that we put on it so you can't slide out of it.
I was going to ask you about that.
But not tight, because when we tilt it up to the standing position, you're actually standing. You're standing the same way, say, a soldier would stand at attention. And that's where you see some of this. If you watch some videos of soldiers in parade grounds standing at attention, every once in a while you'll see one just kind of crumple to the ground and collapse. They'll faint from standing in one place. That's one of the causes, one of the types of syncope that we look for. And so the tilt table lets us monitor changes in blood pressure, changes in heart rate, changes in heart rhythm. The EKG is being monitored. And we leave the table in this upright position. You're standing for about 20 minutes. And after that, the table goes back down to a lying down position, about 5 minutes for the patients to relax, and then unbelt them from the table, and they can get up and go home after that. So it's a very, very simple, non-invasive test.
So, let me go over this again, because this is brand new to me. You get in like a normal bed, then you bring that table up like this. Now, does that make a difference in some people, in a normal response to a change in posture from lying flat to standing upright? We should see the blood pressure and the pulse rate rise very, very slightly. Really?
And we have a number of different normal physiologic mechanisms, reflexes, automatic reflexes, that prevent us from normally from fainting when we stand up from lying down. So essentially we're doing in a laboratory environment what you do every morning when you get out of bed. You've been laying flat on your back in bed, or maybe not on your back, but you've been lying flat, and then suddenly you're upright. And what you've done is you've taken your head, your brain, and you've moved it from being at the same level with the heart to being some, 1.5 to 2 feet higher than the heart is, and the blood pressure has to be high enough to pump the blood up that hill, if you will, straight up to maintain the flow through the brain. And since we're upright beings, we're designed with reflexes that accommodate. Sometimes those reflexes, especially as we get older, may become sluggish or abnormal, and this can lead to feelings of dizziness, lightheadedness, and so on. So that's some of what we look for.
Now, this particular test is right here in Ashtabula, then?
Well, it hasn't been, and that was the whole point. The Tilt laboratory, while it is a very simple laboratory, it's not a particularly exotic set of equipment. But for whatever reason, it tends to be few and far between. And up until the opening soon of our laboratory as part of the ACMC and Cleveland Clinic Heart Laboratory that we have, most of the patients that needed this would have had to have headed west or headed over to Erie or go out to Cleveland Clinic main campus. But between here and Cleveland or here in Erie, to my knowledge, there weren't any full tilt laboratories. And so we've been working to get the equipment together to set this up, and we have the equipment, and we've got the protocols in place. And while I can't give you a grand opening date yet,
right.
But in the very, very near future, we should be able to start doing this test and having it done locally. It's a very safe test. It's a very simple test. It's completely non-invasive. And so there's no reason why we shouldn't be able to do this locally. Now, as I say that, I really want to bring to bear the fact that the laboratory is not a standalone piece. These patients are referred in for evaluation of lightheaded spells, syncope, or palpitations. The tilt test is one of several that we would do to evaluate that patient. And what we would like to do over the course of time is develop a comprehensive, multidisciplinary approach to trying to diagnose these. They're maddeningly frustrating because according to Murphy's Law, they never happen while you're watching.
Right.
So typically a person comes in and they says, well, yes, last week I was working in my garden and I suddenly passed out and I don't know why. Well, none of us were there when it happened. We weren't on an EKG machine or a heart monitor, and so we try to piece together from the surrounding symptoms what the cause might have been. But obviously, unless you're physically there and examining a person when it happens, which is not likely to occur, some of that is guesswork. And the laboratory is a piece of trying to put that puzzle together.
What do you find in most cases when you have somebody that comes in and said they had a dizzy spell or they fainted? What is there a percentage of what that could be?
Well, I'm not sure I can give you specific percentage.
Okay.
And it very much varies, obviously, with the age group of the patient that we're looking at. I see patients from 16 to 90 plus with this fairly common type of symptom. And obviously in a very young age group versus a very old age group, there are completely different mechanisms by which this is going to be the cause. And that's a very important issue. I think there's really two important issues. One is that we need to separate out certain confounding symptoms with this. Patients will come in and they'll tell me, oh, I had a dizzy spell. And you have to find out what that means, because dizzy means something completely specific and different than lightheaded from a physician's perspective. One being this, I'm seasick, the room is spinning, what we used to enjoy when we were little kids, spinning around and stop and the room would keep going. Right. And we don't like it very much when we're adults, but when that happens unexpectedly, that's dizziness. As opposed to lightheadedness, which is nothing's moving. I feel like I'm going to faint. I'm getting tunnel vision. It's getting black. I'm hearing and seeing less, and I know that if this goes on, I'm going to be unconscious on the floor. That's lightheadedness, or what we call pre-syncope, or before or almost.
Right.
And those are two completely different things. The dizziness so typically is vertigo. It has to do with the balance organs in the ear and the brain and so on, as opposed to lightheadedness, which is more often a blood flow to the brain type problem.
I was talking to a guy the other day. He said that he knows a young kid, teenager, extremely high blood pressure. Now, that's kind of rare, isn't it, when you're young, that young?
It is and it isn't. I say that because extremely high blood pressure in the young is a rarity, and it's a very serious rarity that bears investigation, because it usually is not just high blood pressure. It's usually, when we see this, it's often due to other abnormalities that are causing the high blood pressure, as opposed to the type of high blood pressure that we see in older middle-aged adults, which is just part of our makeup, genetics, Western society, and so on. But at the same time, I would say that one of the important abnormalities that's commonly overlooked is high blood pressure in the young adult, even in the teenager. It's just that what we call high blood pressure in a teenager is normal blood pressure only a couple of decades later in an individual. So if I have a middle-aged or older adult with a blood pressure of above 160, that's high blood pressure. But if I've got a 17-year-old with a blood pressure of 125 to 130, which some of us would be very happy to have at our age, that's significant high blood pressure.
Is it really when you're young?
Yeah, it's the beginning of it. I mean, obviously, a typical teenager is going to have blood pressure in the teens up to about 120.
Is that right? Mm-hmm. Yeah, I was going to ask you what that would be.
Yeah.
I did get a question in to ask you.
Sure.
A person out on the West Coast, a friend of our show here, actually, a couple weeks ago experienced what he has called a stroke of the eye. Mm-hmm. Are you familiar with anything like that?
Yeah, that terminology can be used two different ways. One, they can have, when we talk about stroke, we talk about a sudden cessation of blood supply to a certain area of the central neurologic system. So typically we talk about the brain, obviously. Mm-hmm. So one type of stroke of the eye that you might think about is that a small blood clot or plaque obstruction has occurred in the center of the brain, in the part of the brain that controls vision. That is some people may refer to that as a stroke of the eye, although typically that's not what they're talking about. The blood supply to the nerve to the eye, the optic nerve, can also be interrupted by small blood clots, and that can be considered a stroke of the eye as well. But more commonly, when people talk about a stroke of the eye, they're talking about a blood clot that's gone all the way into the eye itself, the blood supply to the eye, and shut off a portion of the blood supply to the retina, the light-sensitive portion in the back of the interior of the eye, and caused a certain degree of blindness in that region. Now, depending upon which blood vessel, if it's the central retinal artery is the main blood vessel, you can lose the entire vision in that eye all at once, and it suddenly shuts off just as if a light switch were turned off. Or you may have what we call a field deficit, where one of the smaller branch arteries is closed off, and a portion of the retina is not functioning after that.
He mentioned that there was retina damage, and that he probably has lost the sight in that eye forever.
Is it his total sight in that eye?
I believe, yeah.
Okay. So, and we see this blood clots that travel in the arterial system on their way up toward the brain, toward the head, assuming they originate in either the aorta or the heart itself, don't have any guidance system. They're just flowing in the stream. And as the blood vessels branch, they take random turns. They may go to the left branch or the right branch in any blood vessel. And it's only going to go as far as the blood vessel that's large enough to accommodate it. Afterwards, it impacts and closes that blood vessel like a cork in a bottle. And if it goes into an artery that leads to a section of the brain, you have a typical stroke. And if it goes into an artery and finds its way into the eye, you're going to get an ocular stroke or an eye stroke.
Have you ever seen instances where the eyesight does come back?
It depends upon, to a great extent, the size of the blood clot that caused it, which artery is closed, whether or not the clot stayed solid or whether it dissolved,
Okay.
which can happen.
Okay.
So it is pretty variable, but a lot of people do have permanent damage to the brain.
Yeah, that's too bad. Love to come back to Connie and fish in our lake here, but he's going to come back still, and probably have to get used to that situation. I'm kind of curious on what that little guy is on your desk there.
Well, as we were talking about episodes of loss of consciousness, and I had said that one of the frustrating things about diagnosing this is that you weren't there when it happened.
Right.
Is that in a select group of patients, as we go through the testing process, we go through various different types of monitoring. And the monitoring may start off with an electrocardiogram and then move on to a 24-hour monitor or even a month-long monitor. But ultimately, for some of our most difficult patients, one of these devices can be implanted under the skin. I can just hold this up for you here.
Look how tiny that is.
Yeah, I can put a
Yeah.
pen next to it. It's really quite small. It's about the size and shape. I'll turn it this way so you can see the thickness of it. It's about the size and shape of a USB drive.
Yeah, it is.
For a laptop computer. It's completely sealed. It has no wires attached to it. And this gets implanted under the skin.
In the chest area?
In the chest area. Procedure takes all of about 30 minutes or less, with just with some Novocaine type drug. And this is a monitor. It is we call a loop recorder. And the loop recorder is very similar, in fact it's identical in many ways, to the so-called black box in the airplane. It's the flight data recorder. It's continuously recording what the airplane is doing, and it stops when the airplane crashes or when something else bad happens. And the investigators can find that and go back and they can ask it, what was the airplane doing for the last hour before this happened?
Right.
Well, in a similar fashion, this has a continuously recording EKG system in it. It's continuously recording a certain period of time, and it's programmable to some extent, maybe 5 minutes or 20 minutes worth. It does have a brain in it, so it is looking for certain types of rhythm abnormalities, and it will store samples of that for us. But at the very basic level, if a person has their symptom, in addition to this, which is implanted under the skin, they also have a little, we call it an actuator. It looks kind of like a pager or beeper, and they just put it over it and press the button, and that tells the recorder electronically to lock its memory. And typically it says, well, the person just had the symptom and it's gone. But it's still been recorded in here, and it'll stay in there for the next 15 or 20 minutes. So if they lock it, we've captured it at that point. So it actually lets us look back in time. And when they come to the office, we can interrogate this device through the skin with a little radio frequency.
You don't have to take it out?
No.
Will it be in there all for the rest of their life?
Well, the batteries in this last for about 3 years.
Then you have to.
And then after that it becomes inert, and then depending upon the patient, we may take it out and put a new one in if we still have not made the diagnosis,
Right.
and if we still feel it's important to do so. That's rare. I mean, something that doesn't happen more than once every 3 years is not something that we're likely to continue to go after.
Right.
Although I did have one patient that was actually 5 years in between events, but they were severe events. He lost consciousness while driving his car, and actually ran off the road twice, and we finally did capture the second one after the batteries ran out on the first. And the second one finally captured one of those events.
Really?
That's extremely rare. Most of the time, within the 3-year lifespan, you're going to either determine that there is a problem and know what it is and treat it, or that there is no problem as far as the heart rhythm is concerned.
So when you interrogate that thing, that's how you could get a diagnosis.
Yes, it's one of the diagnostic tests that we use.
That's amazing.
And then at the end of that period of time, if we've made the diagnosis even before the 3 years are up, or if the 3 years go by and the device has told us specifically that there is no heart problem, if the patient wants, after the battery is depleted, it can be removed, and that takes about 10 minutes to do.
Now, you can't recharge those batteries?
No. No, it's disposable.
One time only. Now, that's got to be a pretty expensive process, huh?
Actually, I can't quote you an exact price on what these are. They are completely covered by insurance. So,
are they?
Yes. This is not new technology. We've been using these for, I'd say, somewhere between 15 and 20 years.
No kidding.
They've been available, and they've become smarter over that period of time. And when we first started using these were just like the black box in the airplane. There was a one-shot memory in it for the single event that the patient.
They've never been that small, though, right?
And no, this was actually the original size when they first came out.
Is that right? That long ago?
And the newer ones, as I said, they have a brain in them. They look for things specifically and record them. And we also have the patients will also have an interrogator transmitter hooked up to their telephone at home. So with these, the patients can send us reports without actually coming to the office.
Unbelievable. That just amazes me.
Part of our pacemaker type technology.
Before we went on the air this morning, it was kind of funny. Tina's with Doc today, and Doc and I were chatting, and all three of us remember Annette Funicello.
Oh, yes.
And from the Musketeer days, and later the Beach movies, of course. She had MS, and she passed away yesterday at the age of 70, which is not that old in today's terms, but she has suffered for a long time, as you mentioned, Doc. In that situation, would that MS have ravaged her so badly that everything seems to shut down, and that's how you passed? Well,
of course, MS is out of my field to a great extent, but from a physician's perspective, it shuts down or causes malfunction of the muscles of the voluntary muscle system, and as a result, people can't move, they become immobile, and that leads to a whole host of additional.
Yeah, I think she was wheelchair bound.
Wheelchair bound, they get pressure sores that become infected. They have problems; they can't control their bladder. A lot of these people will have permanent urinary catheters in, and they suffer from recurrent urinary infections and so on. It's very often that infection is some type of infection is what the terminal event is.
I know she hasn't been able to speak for quite some time. It's just a real shame. And of course, from our era, we remember Annette Funicello. That's a big star in her day. I'm checking to make sure we got all the questions answered here on emails. I think we took care of the one, so that's been handled. We do not know. We are getting this new tilt table in up there, but we don't know exactly when.
Yeah, the equipment is all here. We're going through working out the protocols for how we'll schedule the tests, how we actually conduct the tests. Obviously, we want the first test that we do to be as professionally correct as the 100th test.
Sure.
And so it's not the kind of thing where you want people to be on a learning curve, if you will. You want you want it as expert from the beginning as it has been. These are not new laboratories. I personally have been conducting these tests in other hospitals for many, many years, but anything that's new to an institution and to the staff there. So we're going through the training right now. So I would anticipate that we're looking at no more than another month or two before we're up and running.
Oh, great. That's great. It's a good addition to our county. Had my guest co-host on Fridays is Steve Grant, who is a patient of yours.
Yes.
And he had some very nice words to say for you on air the other day.
I just saw Steve recently.
And he said he did well. He did pretty good at his checkup.
He's been doing very well, and he was featured in one of our heart catheterization laboratory outcomes book last year.
He was telling me about that. I've never seen it. Is it out, and has it been published?
We don't. It's published at the hospital through the medical staff and so on. But if you'd like, we'll make sure you get a copy.
I'd like to see it because he was
absolutely.
telling me about he enjoys that, you know,
Oh,
that
yeah.
publicity. And he says I was actually picked to be like a model, and I go, oh, boy. So I have not seen the outcome of this. I'm surprised he hasn't brought it in and showed us on the air. But
I will bring you one. We can look at it next time. I'm sure.
very good, Doc. Appreciate it. Of course, Doc is based out of ACMC in Ashtabula, and looking forward to seeing you again, probably, hopefully next month or next 6 weeks or so.
Absolutely.
And have a good week, and thanks for coming in. I know you've got a busy schedule ahead of you, so I don't want to hold you up too long, but thanks for coming in, and we'll see you next month.
Thanks for having me, Pat.
Thanks,
It's always a
Doc.
pleasure.
Dr. Perry Fleisher at ACMC.